Good afternoon, everybody, and welcome to the UCLA Center for Health Policy Research March 2019 Health Policy Seminar. I am AJ Scheitler. I'm the Director of Stakeholder Relations here at the Center. I am happy to introduce today's seminar, Economic Insecurity Among Older Adults of Color, Housing and Health as Cause and Effect. Today, we're very pleased to have with us our own Associate Center Director, Dr. Stephen Wallace. He will be discussing elder economic security through the application of the Elder Index and how the housing burden borne by elders, particularly older adults of color, affects health. The Elder Index and his application of this tool gives a more accurate measure of poverty based on how much people must spend to maintain a basic standard of living in different counties in California. Now, looking ahead, our next seminar will focus on another very important topic of the Center's 25th anniversary. We'll review and discuss the E.R. Brown Symposium on Universal Health Care in California. We held a 2-day seminar earlier this month in Sacramento and here at UCLA, and we will be reviewing and discussing what we learned from that 2-day symposium. Please watch your email for the date and time of the next seminar, which will be led by Center Director Dr. Ninez Ponce. As always, today's seminar will be recorded and put up on our website for you to view later. You can also request copies of today's slides by emailing a new address if you've joined us before. It is now healthpolicy@ucla.edu. You can also go online and subscribe to our newsletter where you'll get updates about all of our upcoming webinars. We will be having Q&A at the end of Dr. Wallace's presentation today. If you're online, please use the chat function and we will get to your questions as soon as Dr. Wallace is done. And now, I invite Dr. Wallace to the podium. Thank you.
Great, thank you, AJ. Always good to start by acknowledging funders. The Elder Index has been supported by a wide range of funders over the last dozen years that we've been working on this. The most recent funder to the list of supporters is the Meta Fund, which is a San Francisco nonprofit foundation. We've recently had funding from the Thomas J. Long Foundation, UCLA School of Public Health, many others going back to the Wellness Foundation that was a major supporter of the Elder Index when we first got it going. I want to also acknowledge a senior researcher at the center who spent a lot of time in the recent years helping create, support, and analyze the Elder Index, and that's Imelda Padilla-Frausto, so I want to thank her as well. Okay, so into it. So briefly today, what I'm going to do is to talk about what economic insecurity is, how we measure it, how we should measure it, and then what the relationship is between economic security, housing, and health. And then some possible solutions. So we're a health policy center, so it's always important to think about not just documenting problems, but trying to address solutions for them. So first, what is economic insecurity? Well, the simple definition is an insufficient amount of money to pay for a minimal but decent level of needs. So it's not a starvation level needs, it's not a you can live on this for a couple months levels of needs, but a minimal decent level of needs. If you aren't economically secure, you do the balancing act. Do I pay rent or refill my medications? Do I buy enough healthy food to last until the end of the month or pay my utilities? I think it's safe to say that living in the richest country in the world, seniors who have helped build this country, raised families, and fought in our wars should not have to be forced with these dilemmas. So there's the ethical background. So how do we know that a person is economically insecure? Back in the 1930s, during the Great Depression, there was no specific way of measuring economic insecurity. It was a impressionistic measure. So in Franklin Roosevelt's second inaugural speech, he talked about the problems that the country was facing by saying, "I see 1/3 of a nation ill-housed, ill-clad, and ill-nourished." So there were lots of people out of work, local governments were overwhelmed with people needing assistance, but the government really had no specific measure of economic inadequacy. Fast forward to the War on Poverty 30 years later, and Lyndon Johnson decided that he was going to address economic insecurity by declaring a war on poverty. But to be able to identify whether you're winning the war, to be able to identify whether you're making progress, you need to have a defined metric. And that metric had to be standardized for the country. And in the 1960s, what they were looking for was a number that was high enough that they could make progress, but not so high as to make the country look bad. So there was a political aspect to selecting the metric for poverty. The metric that they ended up using, which we call the Federal Poverty Guideline, or FPL for short, was based on a 1955 survey. Remember, this is the early 1960s. There's not a lot of data available in the country like we have today. And the best data that they had was a 1955 survey of family expenses. And what they found was the average family spent about 1/3 of its income on food. So using that ratio, that families spend about 1/3 of their income on food, remember this, I will quiz you later. They then looked at a Department of Agriculture survey that looked at how much it cost to buy minimally adequate amounts of food. They had 4 different levels of food purchases, and they ended up picking the very, very bottom one called the Emergency Food Plan. That was really designed only for temporary nutrition. It wasn't designed as a long-term food budget. But they took that one, multiplied it by 3, and came up with the numeric definition for what is poor. So there's a couple problems with that. Well, established in 1965, it's been basically the same amount adjusted for inflation. What it hasn't been adjusted for is the changing standard of living. I'll talk about that in a second. Second, because of the limitations of the data at the time, it was a single value across the United States. There is no variation for regional cost of living. The federal poverty level does not reflect the housing type that people are in, and it does not reflect the higher medical costs of older adults. So it's insensitive to age, it's insensitive to housing, it's a single number, and it's based on the standard of living of 1964. Anybody recognize this car? What is it? An Edsel. So this was the state of the art in 1959 when the poverty level was designed. And I would argue that the Edsel, which was the biggest flop that Ford ever made, has a lot of parallels with the poverty line, not just the standard of living. So nowadays, the Edsel had no seatbelts. It had no airbags. It had no anti-lock brakes. Had no USB port. So those are all things that we take for granted these days. You wouldn't buy a car without those. So the standard of living has increased, but the amount of money that the federal government says you need to live on has not in the same proportion. So this shows you dollar-wise. In 1964, the federal poverty line was $3,142. In a lot of European countries, they use a relative standard for poverty, which is half of the median family income. So you look at, you array the incomes of all the families in England, and you cut and you say half the families have below this amount and half the families have above that amount. That's the median. And then so they take that dollar value and say 50% of that median is the poverty line. So that's commonly used in Europe. So if you applied that to the United States in 1964, you'll see that the poverty line that they used was a little bit below what international standards are for poverty. So it was 42% instead of 50% of the median. What you can see, though, is over time, while inflation has gone up slowly, the standard of living has gone up much more. And so in 2017, the 4-person median family income in the United States was $47,000. Half of that was $47,000. And the poverty line was $24,000. So we're now down to 26% of the median family income instead of 42. So the purchasing power compared to the average person in the United States has shrunk. So that's problem number 1. Federal poverty level does not keep up with economic growth and changing standard of living. Number 2, as egregious, is that there was one amount for the entire country. So in 2019, today, you are considered in poverty if you make under $12,490. That's whether you live in rural Alabama or in San Francisco or Chicago or Los Angeles. Would anybody say that that's a rational decision? Okay. So the big driver for regional cost of living is housing. And what this shows you is the Department of Housing and Urban Development, it's the U.S. federal agency, that does surveys of major housing markets across the country and looks at what would it cost if you were renting an apartment today, and then looks at what they consider, what they call the fair market rent, which is the 40th percentile. So this is under half of all new apartments available on the market rent for this amount. So this shows you the range. Brownsville, Texas, a one-bedroom apartment you can rent for $563. That same apartment in San Francisco would be $2,255. And having lived in San Francisco, I suspect that the quality of that $2,200 apartment would be a lot less than the $500 apartment in Brownsville. Los Angeles is also a high-cost city, $1,384 for that one-bedroom apartment. And California in general is at the higher level. There are some rural areas, such as Fresno shown here, is $769. So the regional difference is a fourfold difference in the cost of renting an apartment is not reflected at all in the federal poverty line. Problem number 3, costs differ by type of housing, and I'll show you how those costs actually do differ. But I think what's also important to realize is that the distribution of renters versus owners, and among owners between those with their houses paid off and those still paying mortgage, varies quite dramatically by income. So this shows you nationally that among people whose income is below the federal poverty line, 40.6% up here are renters. So 2 out of every 5 low-income people are renters, and that proportion drops dramatically as income goes up. It's interesting to note is that 40%, 2 out of every 5 persons with income, older adults with incomes below the poverty level, also own their house with their mortgage paid off. So when you look at assets among older adults, the greatest asset for almost all older adults is the home that they own. But if you're low income, you're less likely to have a home, and it's less likely to be paid off than if you're higher income. So being sensitive to differences in costs for owners versus renters is important. Then problem number 4 is that the expenses faced by older adults in particular differ than those by other ages. So, okay, here's the memory test, right? So for cognition and aging, we usually tell people 3 things and then go back a couple minutes later and ask them to repeat those 3 things. So do you remember what proportion of family income in the 1950s was spent on food? 1/3, okay. So you passed the memory test. What this shows is that older adults today, and actually across age groups, this is the food part, the white bar, it's 12 to 13%. So the burden on family incomes of buying food has declined dramatically in that last 50 years. What's increased is the cost of housing, and for older adults, it's the largest single segment of their expenditures, and medical care. So you can see that ages 45 to 54, 6.7% of total income goes to medical care. And people have this image that you hit 65, you get Medicare, and all of your problems are solved. But as you can see, actually the cost of health care as a proportion of total income increases even when you're in Medicare age. So that's 15.5. So those are the 2 largest amounts.
What's included in the cost of
So cost of medical care includes insurance premiums. It's basically any out-of-pocket cost. Yeah. So if your insurance pays for it, it's not included in this bar. If your insurance doesn't pay for it and you pay out of pocket, co-pays, deductibles, insurance premiums, long-term care is a big one, especially as you get in older ages because it's not covered by Medicare. Okay. So the solution is to address those 4 problems. And so the Elder Economic Security Standard Index, which we've been working on for California for about a dozen years now, addresses each of those. It takes into account the actual costs for a market basket of basic necessities for older households. So it reflects today's standard of living, not 1955 standard of living. We calculate it at the county level versus the national level. So even within states, when there's variation, we capture that variation. It's calculated for both owners and renters, so that big difference is accounted for. And it includes out-of-pocket healthcare costs. So this is what it looks like. So for Los Angeles, City of Los Angeles in 2017, just as reference, the federal poverty line was $12,060. If you are a renter in Los Angeles, this is 2 years ago now, the fair market rent for a one-bedroom apartment is $1,177. So you don't need to do higher math. We multiply that out by 12. If you had the federal poverty line of $12,000, could you afford what the federal government says you should need for a one-bedroom apartment? No. Okay, so simply the cost of housing in Los Angeles exceeds the federal poverty line for the country. As you go down, you can see costs of food. This is based on also Department of Agriculture survey. But instead of the bottom food basket, it's the low-income food basket. So it's the second from the bottom. Transportation is based on local transportation only, so no flying to New York for Aunt Gertrude's funeral or graduation. Healthcare costs are based on paying for health insurance for Medicare, as well as any out-of-pocket costs on average in that area. And I'll explain that in a second. The miscellaneous is the rest. So what you get to for Los Angeles is for a minimum basic standard of living for an older adult, you need about $25,000. So that's not even close to what the federal government says the federal poverty line is. Now, when we were first calculating this, we were worried that it would be a little bit divisive because we assumed that costs would be so much higher in coastal urban areas than inland areas. The inland areas would feel like they were being discriminated against. So when you look at Humboldt County, very rural, indeed, the cost of the one-bedroom apartment is much lower. It's $769 instead of $1,177. Food and transportation are similar, but when you get down to healthcare, you can see that there's a great difference. And that's because in Los Angeles, you can get a Medicare Advantage plan for no extra money. So basically, you can sign up for a plan that gives you low copays, no deductibles, prescription medications, and not have to pay anything additional out of pocket. Humboldt County, in comparison, has no dominant Medicare Advantage plan, so we used Medigap policies for medications, for the doctor visits, etc. And so actually the cost of healthcare in rural California is a lot higher than the cost of healthcare in urban. Out-of-pocket costs are higher. And so in Humboldt County, it is less expensive overall, but it's still $23,000. So whether you're in rural or urban California, the cost of a minimum standard of living for older adults is still dramatically higher than it is for the national federal poverty line. And the lowest costs are for those who own their homes and have no mortgage. So they're still paying gas, electricity, health insurance, homeowners insurance, and other costs. And so while you can see the costs actually in Humboldt and LA for long-time homeowners is about the same, that once again is still more than the federal poverty line. And this shows you that overall gap. So $12,060, the federal poverty line, the $24,000 for the elder index renter, $18,000 for the owner no mortgage, and if you're paying off a mortgage, you have mortgage payments in addition, that's $37,000. So in no circumstance do you find that the cost of living in California is actually close to the amount that the federal government says you should be able to survive on. So we've recently put up a series of dashboards that lets people look up both the amounts that people need to make ends meet, as well as who's affected by that. And those are summarized, the two sheets on your table, and the URL on the screen shows you where to get to these. So these provide the ability to look at different years. This says California, but it lets you specify the county if you're interested in Los Angeles or Ventura. it lets you specify the family type, so single older adults, couples with grandchildren. The housing types, I showed you the 3 housing types, renters versus owners. And then below the elder index, or what we call the hidden poor, which is the group that's above the federal poverty line, but below the elder index. So it gives you a lot of ability to look at who's affected by the elder index in a lot of different ways. And the particular slide here actually shows what I showed you earlier, which was, which I'll show you again actually later, which is renters are the worst off, followed by owners with a mortgage and owners without a mortgage. This is just more, it's a very long dashboard. Gives you, oops, come on. Okay, gives you a nice map of the state so you can visualize it along with the county by county comparisons. And then it gives you the actual numbers as well. On a different dashboard, which is the other sheet on your table, and which you can get to by the URL that's at the bottom of this slide, it shows the dollar amounts for similar each county, different family types, and different home ownership types. So with all this in your hands, you can explore the elder index further. But let me just talk a little bit about housing and health. So if you look at the elder index by housing type, what you see is that renters are the most likely to be economically insecure. So the red is, if you look at all older renters in California, and you look at their incomes, older renters, about a third fall under the federal poverty line, which is, I've already shown you, is a dramatically inadequate amount of money to survive on. So that should give you chills to start with. Another third are what we call the hidden poor. It's that group above the federal poverty line, but below the elder index, which is county specific to the needs of older adults in the state. So overall, about 2/3 of renters who are age 65 and over who live alone don't have enough money to make ends meet in California. If you've got a mortgage, it gets a little better. About 40% are economically insecure. But even those who own their home without a mortgage, about 30% are economically insecure. So the challenges of making ends meet in California for older adults is particularly severe. And it should be no surprise that there is racial and ethnic variation. So once again, red is federal poverty line, yellow is hidden poor, and green is above the elder index. So non-Hispanic whites, 3/5 are above the elder index versus about a third of the other racial and ethnic groups. And what you can see is that in all cases except for Asians, the group of hidden poor is greater than the group that the federal government officially defines as poor. So once again, this is living alone, age 65 and over. So what's the impact of this? There's been a lot of attention in the last couple years to the rising unaffordability of housing in California. And once again, housing and urban development defines how much money the average person, average household, should be able to spend for their housing. So if you spend 30% or more of your pre-tax income on housing, you're not considered to have any housing burden. If you spend 30 to 50% of your pre-tax household income on housing, you're considered to have a moderate burden. And this group here, which spends more than 50% of their income on housing, is considered severely burdened. Let's make sure. Okay. So here's who's housing burdened in California. So this is among older adults who are the household head or the spouse of the household head. And not surprising. So what you can see is that if you're an owner with no mortgage, you're the least likely to have any housing burden, versus if you're a renter, this is of all incomes now, you're the most likely to have a housing burden. In fact, once again, about 2/3, close to 2/3 of renters are spending more than 30% of their income on rent, And if you look at the red bar, that's the severe. Those are people who are spending more than half of their income. So about a third of older adults in California are spending over half of their total income on rent. So remember a couple slides back when I showed you that the distribution of spending by category. So this is a group that's disproportionately spending income on housing. So similarly, when you cut it by the income of individuals, it's no surprise those who are below the federal poverty line are the most likely to have housing burden, and those over 200% are the least likely. So housing burden in this sense is both a cause and consequence of economic insecurity. Housing burden is a consequence because if you have very low incomes, you don't have very much money to spend on housing. And it can be a cause, as I will show you in a minute. Okay, so getting a little more complicated here. This is the ownership patterns by race ethnicity for older adults, but only older adults who are below 200% of federal poverty line. So these are the older adults that are generally under the elder index. So if you look at economically, older adults with low economic resources, once again, you can see the proportion in California that own their homes free and clear is about 40% for non-Hispanic whites, a little over a third for American Indians, but much lower for other groups. The renter groups, on the other hand, particularly African Americans, almost 2/3 are renters among this category. So this is a group that's going to be particularly challenged to find housing when they don't have the resources to pay for it. What's interesting to look at is housing turnover. So if people are spending 50% of their income, but they figured out how to manage that, then you wouldn't expect them to move very often. But it should be no surprise that owners without a mortgage have the highest number of years of living in their current home. This, once again, is residents age 65 and over in California. So of all older adults living in a home that they own, where they're not paying a mortgage, about half of them have lived there 30 years or more. Anybody here lived in your same house 30 years or more? So that's about half of old, so we're not older, well, most of us are not older adults in this room. But so there's a large segment of the population that's moved. Both my neighbors on either side of me are in this situation. They bought in the 1960s, and they raised their families. They now have grandchildren, and they're still in the homes that they owned in the 1960s. So they're part of this half of the group that's lived there for a long time. Very few are recent movers. Interestingly enough, very few of owners with a mortgage are recent movers. So sometimes people will sell their large house that they had when they were raising their family, move into something with less maintenance, a little smaller. But in California, at least, there's very little turnover in owners with a mortgage, so they're going to go into here where they're without a mortgage. Renters, on the other hand, have a high turnover. So over 2 out of 5 renters have been in their house for less than 5 years. So there's much more of a churn of people who are renting. And that could be for a variety of reasons. It could be because they can't afford the rent. It could be because they're looking for a different neighborhood. There's problems with the neighbors. But I think what's important is that renters have a very high rate of looking for new apartments. And going back to the cost, the fair market rent, that's the cost of finding a house today. So if you'd been in your apartment and you're in Santa Monica or San Francisco and had been there 30 years, you would be under rent control, and the cost of that apartment would not be as high. But most California cities do not have rent control, and most seniors in California who are renters are constantly looking for new places, so they're going to be exposed to those high costs of living. So what happens if you're not in a rent-controlled unit and you're forced to move, forced to be one of those 1 out of 4, 40% of seniors who have to move repeatedly? If you can move down the street, it might be an inconvenience. But if you're moving because of the cost of living, the chances are that you're going to have to leave the community that you're in. So for example, in Santa Monica, they've got a new program that they're building out designed to help keep older adults who are in rent-controlled units in their rent-controlled units when they can no longer afford them. So rent-controlled units can go up a couple percent every year. Over 20 years, that can actually result in a fairly large rent increase. If you're on a fixed income, if you're on SSI, your income's unlikely to keep up with that. So what happens if you have to lose your rent-controlled apartment in Santa Monica, or you're in West LA and you had a nice landlord who didn't raise your rent very much, and then the building sold and now you're facing a large increase? So you're not going to be able to find anything local. You'll have to move further away from your current source of residence. And that has a whole set of potential health consequences. Health consequences including weakened social networks. There's a lot of research now that looks at the impact of social isolation, and the current rule of thumb is that if you're socially isolated, it affects your health about the same as smoking a pack of cigarettes a day. So weakened social networks is actually an important health problem. In addition, older adults use medical providers regularly. They have more health problems, and so if you're moving from Santa Monica to the Antelope Valley to find that low-income apartment, all of your healthcare relationships are going to be disrupted. Your primary care provider, your pharmacy, the person who helps you get to the doctor when you need to, all of those are going to end up in weakening the relationship with your healthcare provider, which is an important aspect of quality of care. And you are also likely to see a decline in access to community services. So once again, using the Santa Monica example, there's a large range of senior centers, in-home supportive services, transportation services. So the city has a full array of social services to help older adults in need. If you move to a less resourced area, then those services are likely to decline as well. So this points out the importance of the interaction of healthcare and housing and economic security, all of which can relate to declines in health, and in addition, health can result in problems with housing. Okay, one way of looking at the impact of economics on healthcare, or on health, is by looking at older adults who say they have problems paying their medical bills. So remember I showed you that older adults pay more out of pocket, a larger proportion of their income out of pocket than younger adults. And as a result, a number of them face problems paying medical bills, even with Medicare and Medicaid and all the other programs. So this is national data. If you look at the state data, basically the patterns are the same. The far right-hand blue bar is the West Coast. In California, the most recent California Health Interview Survey, 2017, showed that about 9% of seniors who are below the elder index reported difficulty paying their medical bills, versus about 3% of those with incomes above the elder index. So about a threefold difference there between different income groups. And that's about the same as you see in this national data. So when you control for all the things that might predict difficulty with medical bills, so this is from a logistic regression. If you're not a statistician, don't worry about it. Just this, what this does is this says, okay, so people who are sicker are going to have more medical bills, so that might explain it. So sorry for all the abbreviations. SRH is self-reported health. So if your health is poor, lo and behold, you have more trouble paying your medical bills, as you'd expect. Activity limitations. So if you're disabled, you're more likely to have higher medical bills, and 1.7 times more likely to report difficulty paying them. I'm going to skip over this. The older you are versus younger ages, actually you're less likely to report having problems paying medical bills. If you have Medicaid, Medi-Cal in California, you're less likely to have problems paying medical bills. And so here are the key ones. If you're a renter versus an owner. So over here I've already controlled for income. So even with the same income, if you rent your place versus own your place, you're 50% more likely to report difficulty paying medical bills. So once again, getting into the housing type and housing challenges, the issues of rent burden become a problem that spills over into the area of being able to pay for the medical care that you need. The other part that's interesting here is when you look at income. So this is comparing those who have higher levels of income to those below the federal poverty line. So those above 200% of poverty, makes sense. You would have less trouble paying your medical bills if you have more discretionary income. This one is not significant, but close to significant. So if you're in that hidden poor group, that 100 to 200% of poverty, you're actually trending, although it's not significant, towards having more problems than people who are under poverty. And that's most likely a result of people who are under poverty having Medi-Cal or Medicaid, and this hidden poor group being too wealthy to qualify for public programs, but not having enough resources to pay for the needs that they have. And then in addition, independent of all those other things, African Americans are more likely to have difficulty paying medical bills. So there's a interaction of race and homeownership and income that becomes an important issue in being able to pay for your bills. So if you can't pay your bills, one of the ways that you can try to make ends meet is to skip medication. So I started off earlier about the balancing act and balancing up between, do you buy enough food, do you buy your medications, do you pay your rent? And so this shows older adults who report that they skipped medication doses specifically to save money, not because they had an adverse reaction or because it made them feel funny, but specifically to save money. So only 3% of seniors said that, so that's up in the title just for transparency. So it's not common, but what explains it? Okay, so once again, it makes sense. If you're having trouble, well, we'll start on the right-hand side. If you're having trouble paying medical bills, that is the largest predictor of skipping medication to save money. Makes sense, right? So that's an indicator that you're having to make the balance. So you're 7 times more likely to say you skip medication if you're having trouble paying medical bills than if you don't say you're having trouble paying medical bills. Even after controlling for that, renters are more likely to skip medication. So getting back to the housing and health conundrum, and renters having more challenges in being able to keep up with current expenses. Medicaid helps. Medicaid pays for medications. Worse health, you're more likely to skip. And once again, the income here is a little more of a straight line. So if you're below the poverty line, and then if you're hidden poor compared to below the poverty line, you actually are slightly less likely to skip doses, probably in part because of other resources. And then the highest income is the least likely. And in this case, the racial and ethnic variation is Latinos compared to whites, saying they're less likely to skip doses. And we can talk about that in Q&A. That could be a way that people interpret the question. But the big take home here is the relationship between ownership, renting, and the medications that you need to keep yourself healthy. All right, so what do we do for all this? So there's a couple easy directions. If you're talking about the amount of money that you have versus the amount of money you need, there's 2 clear areas. One is to give people more money to have, so increase income. That can occur over the life course by raising the income floor during the working years. So California's moving towards a $15 minimum wage as a way of trying to create more economic security in younger ages, which should have a spillover effect into older ages. We can improve pension coverage. A large proportion of the population has no pensions other than Social Security, and so that reduces their access to income in old age. And we can provide caregiving credits within Social Security. So Social Security rates are lower, especially among women who take time off for raising children or for caring for older adults. If they were given credits towards Social Security when they retired, they'd have more income in old age. Those are all areas that can be done. Other areas include increasing the minimum for Social Security that it'll give, as well as the SSI level. There's been efforts in California. During the Great Recession 10 years ago, we cut SSI benefits, and they are just now starting to catch up, so we're still catching up there. And then, once again, we can talk about this later, but there's been proposals to change the way we calculate the CPI, the inflation index. And Social Security benefits are tied to the inflation index. So if you monkey around with it in a way to make it lower, then by definition, as time goes on, older adults will have less income. So that's the income side. The needs side, as I showed you, the biggest cost facing older adults is housing. And in the area of having problems paying medical bills, skipping medications because of the problems of paying medical bills, housing is going to be a major driver. So we can do supply side by increasing affordable housing, and that's for both purchase and for rentals. We can follow Santa Monica's lead, and Los Angeles is now starting to do something similar to assist those who are in the most severely rent-burdened situation so that they can retain the housing that they have. And then in the long term, we can try to link housing assistance to healthcare funding. So California now pays basically no housing costs out of Medicaid, but if we're able to tap into some of the health funding to help maintain people at home, then that would help decrease their cost burdens. Or we can help older adults by both decreasing the need for health care as well as decreasing the cost that they pay for it. So improving health in earlier life is a nice life course approach that everybody benefits from. And if you're healthier earlier in life, you'll be healthier later in life. Once you reach later life, we can try to reduce out-of-pocket medical care costs by expanding Medicaid eligibility. In states that have not done Medicaid expansion, such as in Texas, you have to have an income of 74% of the federal poverty line as a senior to qualify for Medicaid. So Texas is less expensive than California, but I guarantee you that 74% is still below what it takes to make ends meet in Texas. And then finally, we can increase the availability of low-cost Medicare Advantage plans that provides an option for older adults to get into plans where their costs are capped and are often lower. Some people don't want them, so I wouldn't advocate requiring that, but the availability in places like Humboldt County, where it's not currently available, would help seniors up there. So in conclusion, it's important to use a valid measure of economic security, one that is not a single number for the whole country, that takes into account changing standard of living, one that adjusts for housing costs, and one that really addresses the costs that seniors face on a day-to-day basis. Economic security, when we look at it that way, is actually much more common than acknowledged among older adults. So when you look at California statistics for just poverty overall, it looks pretty low and doesn't seem like an issue that we should really be paying attention to. When you look at economic insecurity, it becomes a much broader issue. And when you start looking at groups such as renters, racial and ethnic minorities, it actually becomes a frighteningly high statistic. That's number 3, is variation by racial and ethnic group. And the relationship between healthcare and housing and economic security, which is number 4, demands that we do something about this, which could be through increasing income, as in number 5, and or decreasing the costs that older adults have to face. And that at the end of the day, if we reduce economic insecurity, the net effect will be to increase health equity. So the relationship between between economics and healthcare outcomes means that we can improve health equity by paying attention to economic insecurity. So I actually left time for questions. I worked hard to do that.
Dr. Wallace, because we do have several questions already coming in online, and I will go back and forth between the questions that are online and questions from in the room. So the first one online One of this person's areas of research interest is end-of-life care for low-income and homeless older adults. This person is curious to know if end-of-life expenditure was accounted for in the analysis and would also welcome recommendations of resources or programs on this topic.
Okay, so the healthcare costs are an average across all seniors, and if you look at where the most expensive time in a person's life is, it's the last year of life. So what we're doing though is we're taking the 5 million California seniors and saying, overall, what's the average healthcare cost for that group? So the very high end-of-life costs are going to be spread out among everybody. But yeah, so end-of-life is a particularly expensive time, and if you're economically insecure, you're a renter, you have no savings, and especially if you don't have Medi-Cal, that would be a period that would be particularly fraught with economic.
Hi, I'm Henry Gascon with United Way. Do we have a sense in terms of what percentage of seniors below the elder index live alone? And for those, what kind of support systems do they get from their immediate family and from their extended families?
Okay. Thanks. So I'll also call out United Way. They have a companion measure called the Real Cost Index. Real Cost Measure, which for seniors builds on the elder index, but is for all ages. So it's a nice way for looking across California if you're interested in more than just seniors. So you wanted me, so I looked at columns, you wanted me to look at rows. So what proportion of those under the elder index are live alone? And
what kind of support systems do they have among their immediate family?
so with the dashboard, I won't do it in real time, but we could sit down and in 5 minutes answer that question. Of those below the elder index, my guess would be a third, 40%. That's just off the top of my head. But we, like I say, we can actually sit down and come up with the exact number. So resources for that group. That's an interesting question because there are very few programs that I'm aware of. I don't know if you're aware of any that specifically target older adults who live alone. There are programs for transportation, for meals for shut-ins who are often living alone, so home-delivered meals. If you've got a partner, you often don't need them. If you're living alone, you're more likely to need them. Do you know of any programs for older adults living alone? Right. So if you look at sources of income, so what's interesting, back in the 1940s, 1950s, the primary source of income for older adults was family members, and working. And that was before Social Security really built up to a level where you could live on it. People lived together more often. Multi-generational households were common until the early 1950s. And once older adults had enough income to be able to afford to live on their own, they just look at the demographics, they started moving out. That was before there was any sort of cultural shift, say in the 1960s. So economic transfers between generations, actually from age 65 to 74, the net transfer of funds, I don't know how that gets broken down, but I do know the net transfer of funds is from seniors to non-seniors for that, right? So if you can imagine like helping your kids buy their first house, or your daughter's car breaks and doesn't have money to fix the car, or there's all sorts of things that even if you're retired on a fixed income, you're more likely to try to help younger generation. And it's after that age, as people become more physically disabled, that the income transfer starts to go in the other direction.
Thank you. Next question from online. What part does gentrification play in urban areas in Los Angeles as well as Northern California where low-income and elderly people are being forced out of their homes where they have lived for years?
So gentrification is an interesting topic. California provides sort of a natural experiment where you can look at cities and counties with rent control versus those without. So I've looked at San Francisco a fair amount because, well, you just looked at the numbers, right? It's twice as expensive as Los Angeles. But when you look at the proportion of older adults who are rent burdened, it's actually lower than Los Angeles. And that's because it's it's got a relatively old housing stock and a long time rent control. For many years, even when you moved out of the place, that the unit remained in rent control for the next person who came in. They now have vacancy decontrol. But for people who've lived in their apartments for many years, they haven't been exposed to that high cost of rental housing that I've shown you yet. So gentrification in San Francisco among renters is an issue, but if it's in people are in rent-controlled units, it's less of an issue for them. I do know just from a number of friends and acquaintances who live in that area, there's still the terror of people living in rent-controlled units that the owner will die, the unit will be sold and torn down for luxury apartments, and then they'd have to move outside the Bay Area. That's another one of those examples of if you're forced to move, if you're living in rent control unit in San Francisco, just like in Santa Monica, you lose that unit for whatever reason, you're not going to be able to move to Daly City or San Mateo. They're just as expensive, or even Oakland these days. So you're going to go out to Stockton, or you're going to have to head way inland. So gentrification is an issue, and the shortage of low-income housing becomes a major problem within that.
So we do actually, in some of the projects we're doing, noticing more homeless elderly. And I think your data really seems to be consistent in supporting the idea that that housing insecurity and affordability is actually translating into more people not only being forced out of their home, but ending up as homeless. This is just a comment about relationship between what you're saying and what's happening in real life. And I mean, we're looking at some of this data. We don't necessarily have the final results to sort of share to see how many people are actually sort of experiencing that. But and then in regards to what you were saying, California currently does have a demonstration, 1115 Medicaid waiver demonstration that is called Whole Person Care, and assisting with housing is an important part of that demonstration. Now, what's going to happen with it is a different question, because that then ends up at a higher level with CMS's decision to sort of support whether they will support continuation of these demonstrations that help the state figure out alternatives or not. So that's really unknown.
I'll just mention Dr. Parada's involved in evaluating whole person care, so she probably knows the ins and outs of that better than anybody else in this room. In terms of homeless older adults, just as we've talked about the hidden poor, I suspect there's probably as many hidden homeless as there are registered homeless among seniors. So you've got people that are temporarily staying with children, or that have doubled up with friends and neighbors, or in a whole range of precarious housing situations. So they may not be on the street, but they're not in a long-term stable rental situation. That's hard to measure. And
while I'm pulling the next question from online, I want to throw a thank you out to your colleague, Dr. Imelda Padilla-Frausto, who is online in the chat, also answering some of the very many questions that we are getting as we are going to go over time here, I think. Yes.
I did acknowledge her in the
She is always
She's still working, always working, right?
This person would like to know if there are any protections that have or will be put into place to protect vulnerable populations from being displaced. I know you talked about a few in your presentation, but is there anything else that you're aware of?
Protections for vulnerable populations being displaced. So you read in the news all the time about various efforts to prevent low-income housing being torn down, or if it is to be replaced with equivalent numbers of below-market rate units. The problem with those attempts is usually you'll tear a place down and it's 2 or 3 years later before the new units are available. So either you're homeless for 3 years, or you're moved somewhere else, and then moving back, I don't know what the rate is of people of the original renters reoccupying new space. Zoning requirements are a big area. There's an ongoing battle in a lot of communities now around apartment owners who are changing their apartments to Airbnb, which decreases the housing stock. That's not always low-income housing, but sometimes it is. And I don't think there's any protections for those individuals. I do know that in rent-controlled cities like San Francisco, if a new owner is buying a rent-control building and tears it down, they have to pay relocation expenses to current residents. So that's some protection, but then once again, you're relocating usually 40, 50 miles away. So it's all of those relocation problems, especially for somebody who's lived in the same neighborhood for a number of years. I don't know if there are other proposals. Anybody else here? It's a knowledgeable group.
Hi, Nicole Knight from California Health Report. Hi, you mentioned that 40% of seniors have to move repeatedly, and I was wondering, can you be specific about what you mean by repeatedly? And when you say 40% of seniors, can you talk about whether these are people of color or who these seniors are?
Okay, so that was the different housing types. So among renters, 40% live in the same unit for less than 4 years, and then that's a group that is then a large proportion of them are then likely to have to move again. And then some of the people who've lived and rented for a long time are going to be in the new renter group. So 40% of people are relatively new renters. So that's from the census data. I don't actually know the characteristics of that population, but once again, and just like with Henry's question about what proportion of economically insecure are single older adults, we could sit down at the computer, it's publicly available data, and look at that group of people who have relatively short tenures in their rental units, and look at their characteristics by race, ethnicity, and other, are they living alone, are they part of a couple, and so forth. But that's an excellent question, because that does relate to who's going to be the most vulnerable in those situations.
I realize you cannot see the incredible conversation that is happening in the chat box online right now, but it is talking about the differences and the impact on women versus men, given that many women that are now older did not necessarily work their full lives or worked under pay inequality. Can you speak to any of that here in our closing remarks on today's webinar?
Sure. So we have a whole series of reports, some which Dr. Patia Frausto, who's on the chat, has been lead author on, others that I and others have been lead author on, and we do have some reports that look at the breakout by gender. And once again, in the dashboards, you can pull that out to look at. But older women are much more economically insecure than older men for at least two reasons. One is older men are more likely to be in couples. So you're more likely to have two incomes, even if the spouse was not in paid employment, the spouse can get Social Security as a spouse. So you sort of have an income and a half. If the spouse was employed and has enough income to have an independent Social Security, then you've got sort of two incomes. Older women are more likely to be living alone, so automatically the total amount of income is down and reduced significantly more than the lesser cost of living by having one less mouth to feed, right? So if you're in a one-bedroom apartment, the apartment is going to cost the same whether you've got one or two people in it. So older women are much more economically insecure, and it rises with age. And part of that is both increased needs as well as decreased incomes. And for all the things that you mentioned from the chat, so lower wages for the same work, taking time out of the labor force. I mentioned that as one of the solutions is to provide credits for caregiving time. And then the generation that's in their 70s and 80s is less likely to have worked outside the home for significant amounts of time. So all of those combined conspire to create larger challenges for older women.
Thank you very much. So thank you very much, Dr. Wallace, for this obviously very invigorating conversation today. Please check your emails for an announcement about the date and time for our next webinar, which will be in April, on the Universal Healthcare Symposium that we held here at the center a few weeks ago. If you have not signed up for our newsletter, please go to our website and sign up, and the announcement will